Morning, everybody. We'll just wait. I love how on time everybody is. 34 people before the bottom of the hour. That's fabulous. We'll just wait a few minutes to get everybody on, and then we'll get started. I think that's a record, Megan. I don't think we've ever had this many people before the bottom of the hour.
Ah, excellent.
Maybe because they're deprived of, we haven't had province-wide rounds since January 5th, so maybe just all eager to.
There's some nice ones scheduled coming up, I see as well.
Great. I'll wait a minute or two. It's new magic number. Well, in the interest of time and to make sure that we have a lot of discussion, maybe, and because everyone's been so prompt, we'll get started. For those of you that haven't been here before, welcome. This is some housekeeping things about typing your questions in the Q&A box. If you want to ask a question orally, you can raise your hand and we'll unmute you. And if you have any problems, you can, technical issues, you can email Sidoni at the number that you see there. This will be recorded and posted on the BC Renal website. So that's great for those who want to return to it. Next slide, please. So we're hosting this session on the unceded ancestral territory of the Coast Salish peoples. That includes the territories of the Musqueam, Squamish, Tsleil-Waututh nations and the Métis chartered community of the Lower Mainland region. And all of you, no matter where you are around the province, are on those territories. And we very much look forward to increased learnings, understandings, and appreciation of the lands that we're on and the people that have taken care of them for so long. And we commit, I think, as Canadians to carry on with that tradition. Next slide. So province-wide rounds is a collaboration between the University of British Columbia Division of Nephrology and BC Renal. It's supported with unrestricted educational grants from our industry partners and importantly by all of you within the different health authorities who both attend, participate, and promote these rounds. So thank you for that. Next slide. So it gives me great pleasure to introduce Dr. Megan Borkum, who's an internist and nephrologist originally from Cape Town, South Africa. After she finished her training there, she completed a hypertension fellowship at the University College London, and then a UBC advanced nephrology training and a home dialysis fellowship. A perpetual student, she is currently a second-year BC Renal Research Scholar and enrolled in a Master's in Health Administration program at University of British Columbia. Her clinical and research interests include home dialysis and cardiometabolic disease reduction in chronic kidney disease and dialysis populations. And so today she's going to speak to us about findings related to home dialysis therapy programs that she's working on. So I'll pass it over to you, Megan.
Thank you very much. So I'm very happy to be here today to share with you all the work we've been doing around this project. It's been a passion project of mine. I'm not just going to talk about the project, but also about some theories behind the topic in general. And I've been very lucky to have Dr. Copeland as my project supervisor. So thanks everyone for being here. So since I have unfortunately no disclosures, I'll use this slide for some definitions and clarifications, acknowledging that we have a varied audience here today. When I use the term home therapies, it's referring to peritoneal dialysis, PD, and home hemodialysis, HHD. I'll use the term facility-based hemodialysis, and this refers to nurse-led dialysis units in hospitals and in communities. And then I'll use the term nurse navigator just because that's a term I'm familiar with, and this is synonymous with the transition nurse role. Briefly, our learning objectives for today. So understanding the current state and best practices for screening and selection for home therapies, reviewing the home therapies referral process with findings from our extensive province-wide environmental scan that we've conducted, and what patients want at this time in their journey. Discussing the next steps for the standardized provincial guidance document of the process, and finally, identifying research and knowledge gaps and possible next phases of this project. So looking at our home therapy numbers in BC, so there's been a lot of work on our metrics, and I'm just showing you some gross metrics. But as you can see from this graph, our absolute numbers of patients on home therapies are gradually increasing, especially post-pandemic. Though, if you see on the graph on the right, the absolute percentage of patients on home therapies out of our entire BC dialysis cohort has been fairly static, fluctuating between 30 to 32% over the last 10 years or so. Acknowledging that, like I said, there are nuances to any metrics. Compared to the rest of the country, our numbers are fairly good. Canada-wide is about 26%. Remember, we're seeing the slow trend despite numerous provincial and program-led interventions and initiatives, both from the patient and provider side over the last few years, aimed at increasing the uptake of and reducing attrition from home dialysis. Our PD Assist program, transition guides, best practices work, and emergency preparedness, to name but a few. We're fortunate to have a mature, multidisciplinary provincial program, which is well structured from a geographic and functioning perspective. But as we're all aware, unfortunately, many facility-based dialysis units are over capacity. We have an aging and growing dialysis population and are faced with other challenge, chronic understaffing and rapid staff turnover. So it makes sense then that increasing home therapy numbers is a clear logistical as well as ministry priority. And how do we do compared with the rest of the world? So countries with high utilization of home dialysis have implemented PD first policies such as Hong Kong. They've achieved a great stats of a 2-year technique survival of 82% and patient survival of 91%. However, this is achieved with PD expertise built over decades. Canada, Australia, New Zealand, as well as multiple Scandinavian countries have a home dialysis preferred policy. Of course, transplant first in our setting is always the goal, and modality selection is largely a personal choice, as our patients are fortunate to have access to obviously established facility-based hemo, but PD as well as home hemodialysis. And home therapies are possibly better. Clinical outcomes are fairly similar across dialysis modalities, but studies are limited comparing facility-based hemo and home therapies, and they're mainly observational, meaning that the evidence is possibly of a lower quality. We know that home therapies have some planetary health benefits. For example, the lower carbon footprint from reduced travel carbon emissions compared to facility-based hemo. Referencing Dr. Shannon Wong's poster from BC Kidney Days, I did learn something. There are also some other suggested advantages of home therapies. With PD, there's better preservation of residual kidney function. With physiologic benefits, fewer hospitalizations are seen, and patients have a better quality of life in certain domains. And these are particular to the physical component scores of quality of life. Also with possible improved short-term survival compared to facility-based hemodialysis. Looking at home hemodialysis benefits, these include improved blood pressure, phosphate, and better sleep quality compared to facility-based hemodialysis. So the expansion of home dialysis within a given system is complex and depends where you are in the world, factors vary. And it's governed by multiple factors. So specific to our context, firstly, the healthcare system. In our case, patient costs for home therapies are largely covered, and it's a home therapy preferred system, as I said. Then provider factors. So locally, providers are doing a lot right, as reflected in the green. This includes our wonderful KCC patient education, as well as our assisted PD program. There's an increasing number of providers that are able to perform bedside PD tube insertions. But as we saw in the environmental scan, there's still some particularly geographic challenges with access creation. There's a varying level of comfort with home therapies among providers. We haven't explored this locally, but a lack of clinical exposure or longitudinal follow-up opportunities is even recognized by nephrology fellows. And this creates a disparity in comfort levels with home therapies compared to the more facility-based, the more comfortable and familiar facility-based in-center hemodialysis. But we are getting there. For example, the PD Basics course, currently 36 KCC nurses and nurse navigators have been sponsored to take the course by BC Renal to provide them with the basics of PD care and competencies. And we also have a thriving home dialysis fellowship program, of which I was lucky enough to be a part of. Unfortunately, physician and healthcare team bias and misperceptions in modality selection exist locally. I'll show you data reflecting this on the next slide. Peer-to-peer support is also only starting to be recognized and has yet to be integrated into care. From a patient perspective, socioeconomic factors such as home environment and ability of support and personal preferences. For example, this is something we hear a lot. I want my dialysis at home and my home life to be separate from the hospital. And these things play a vital role in modality decision. In BC, misperceptions and bias among kidney care providers do exist. Just to refer to this 2021 paper by Chris Poinen and team, 334 BC kidney team providers were surveyed. Team members were shown to have substantial differences in perceptions towards home therapy candidacy, and structured maintenance provider education sessions were suggested to address this. Remembering, though, that through a KDIGO lens for shared decision-making, which we know is a key component in patient-centered healthcare, in kidney replacement therapy, quality, education, and support for healthcare professionals, patients, and their healthcare partners around home therapy are priorities. So finally, moving on to the project itself. So in the 2022 Home Dialysis Current State Review and Patient Experience Survey, we recognize that across BC, programs have different ways of screening and referring patients to home therapies, resulting in possible inequities in access and opportunities for our patients. Communication gaps also exist between modality programs and with patients and their care partners. A need was then established for a consistent provincial process as well as communication pathway to mitigate these discrepancies. So our first step in planning this mixed method project was to understand the issues in current state. We formed a multidisciplinary pan-provincial working group, as well as conducted a formal scoping literature review regarding screening and selection for home therapies. We identified current processes and core themes for screening and referral to home therapies via a province-wide environmental scan, as well as a PD and home hemo nursing live case-based scenario workshops, and also building on the larger patient experience survey, patient partner surveys were conducted to more closely understand what patients and their care partners need to better support them at all stages in the modality decision-making process. The results were then collated with coding of qualitative data to generate a guide, with the hypothesis that implementing this guide for screening and identifying eligible patients currently on facility-based hemodialysis for referral to home therapies will increase uptake. Throughout the process, updates were communicated provincially via short presentations. You all saw me at your committee meetings, and I thank you for your attention, as well as at administrative meetings and with our working group at regular intervals. So I'm going to take you quickly through our scoping review just to give you some more background. This was led by Ryan Ting, who's a second-year IM resident. We sought to better understand the utility of tools and guides used in systematically screening and selecting patients for home therapies. We searched online databases to identify papers published between January 2007 and May 2023 on the topic. We chose studies that were only published after January 2007 because it was in this period that home therapies became more widely used for end-stage kidney disease treatment, and policies and practice development and evolution began at that time. Ultimately, after initial screening, 2,588 articles were identified, and a total of 23 peer-reviewed primary and secondary studies met the study inclusion criteria. And I'll discuss only some of the key takeaways from the review. Our first key takeaway was that many previous contraindications to PD are no longer relevant, and it revealed a discrepancy between provider-perceived and actual knowledge, particularly regarding contraindications to PD. Studies in recent years report that obese individuals starting on PD have similar outcomes as non-obese individuals, and therefore obesity should not be considered a contraindication to PD. Similarly, successful laparoscopic placement of PD catheters in patients who were previously excluded from PD due to a history of extensive abdominal surgery is well documented. And ostomies and liver disease are no longer considered contraindications to PD. These discrepancies, variable knowledge, and misconceptions underscore the need to maintain education for providers, thereby eliminating bias, which is a huge problem in this area, to create a more informed and modern approach to understanding PD candidacy. A limited number of guides for evaluating patient eligibility for home therapies were identified, and again, they had variable use. Firstly, the MATCH-D criteria, which I'm sure many of you have heard of, was the most frequently referenced screening tool. However, it does lack a distinction between contraindication and barrier to PD self-care. It gives us a useful framework for assessing and overcoming potentially modifiable barriers to home therapy. The JPAT tool demonstrated utility as an adjunct to MATCH-D for evaluating home hemodialysis suitability and as a tool to evaluate patient self-care ability for home hemodialysis and assess the resources required for patient training. The PD practice ability tool was specifically developed to assess the self-care ability of PD patients. Importantly, variations in assessing patients and not having clearly defined criteria for eligibility led to a decrease in incident home therapy use. Finally, evidence indicates that satisfaction, compliance with therapy, and overall quality of life are improved when individuals are provided with the opportunity to make informed decisions. The provision of pre-dialysis education promotes informed decision-making, empowers individuals to actively engage in their healthcare, as well as make necessary lifestyle adjustments and seek appropriate support. Very important in this area, as it ultimately contributes to positive home therapy outcomes and treatment satisfaction. Provider knowledge, though, which is not clear and up-to-date, may create gaps in messaging and highlight inconsistencies to patients, dissuading them from choosing home therapies. So we concluded, as with many research studies, that further research is required to evaluate tools for screening and evaluating patients for home therapies, as well as collecting evidence on their value when used regularly versus not. More work is also necessary on standardizing the screening and selection process, as well as refining and validating this process and better understanding the optimal type, timing, and interval of provider education. So based on the review, ideally a clear, up-to-date patient and provider education and a modality decision-making pathway with consistent screening criteria, well-informed interdisciplinary support, and family involvement are needed. This will allow for collaborative decision-making, as well as patient empowerment, mitigate bias, and best identify a patient population suitable for home therapies who will hopefully have optimal outcomes. So after all of that, moving on to findings from the provincial environmental scan. So the scan was conducted between May and August of last year. The semi-structured provider questionnaire had 26 questions. It was designed in such a way to provide a comprehensive evaluation of knowledge and practice regarding screening for home therapy candidacy, as well as evaluating and referring patients to home therapies. The questions included details particularly on staff roles, documentation, and communication pathways used, as well as the frequency of processes and required and currently used resources for the process. We asked providers as well to identify local barriers and make suggestions to help improve the process in open-ended questions. The patient partner 12-item questionnaire sought to understand preferences, experiences, and requirements to support them in being considered for home therapies and deciding to start home therapies. Suggestions could also be provided and raised in open-ended questions. The provider survey was conducted by various working group team members, including our home dialysis fellows, Lucas and Leanne. Lucas is unfortunately back in Argentina. And it was done either in person or on video call format. It had a fair, as you can see in the grey table, it had a fair provincial reach and representation, with predominantly nursing roles surveyed in various facilities in each health authority. You can see by far the majority of the respondents were PCCs, followed by nephrologists and staff nurses, and then the nurse navigators. Known BC Renal patient partners from different modalities gave of their time to be interviewed over video call, and we gained a lot of insights from them. They were demographically all over 50, with some tertiary education. So in broad strokes, 5 steps came out from the questionnaire as general key elements in the process, and therefore we built them into the process framework. These being identify, screen, offer home therapy, refer to home therapy, and home therapy confirmed. We realize that for a variety of reasons, the modality choice is sometimes made by the team rather than by the patient. So to ensure that the process is followed in all cases and patients are given the benefit of the doubt, we recommend a systematic approach. And this will allow patients to have the opportunity to advance as far as possible throughout the process. Cross-cutting themes include continuous engagement with the patient and their care partners, especially if timelines are extended, as well as enabling peer support where appropriate. So I'm now going to go through each step in more detail. The first distinct step is to identify all potential candidates. Recognizing that KCC has a well-established process, this pathway is particularly intended for HD units. This would capture not only urgent starts, but it would also capture potentially overlooked patient populations. And examples of these patients include pandemic parachute patients and other new starts who had little exposure to KCC due to presenting late, or those who perhaps weren't receptive to modality education pre-dialysis due to being overwhelmed, as well as those dialyzing acutely who have not recovered sufficient kidney function and are now transitioning to chronic dialysis. We would also capture transfers from other centers and transfers from other modalities such as transplant. Looking at who is reviewing the modality choice, the modality decision with patients, both in KCC and HD, it was predominantly the multidisciplinary team option, then multiple providers, being 2 or more providers. Specifically in the HD unit, home therapy candidacy was only reviewed routinely in 17% of cases, and this is depicted in the pink bars. It occurs predominantly on an ad hoc basis, meaning where necessary or as needed. The second step is to screen for absolute contraindications. Now, an absolute contraindication is a factor that disqualifies the patient from doing home therapy, regardless of the physician or patient choice. So looking at who screens for absolute contraindications, this falls to nephrologists and home therapy nurses in many cases. Looking at what criteria are used, we found that programs use varying criteria, and ultimately, predominantly a mixture of defined criteria and professional opinions to screen patients for home therapies. Of course, only relying on opinions and pre-existing ideas without objective criteria may encourage bias, remembering that there's been growing literature over the last 10 years dispelling long-held myths about home therapy's candidacy. So this is a great quote from one of the KCC nephrologists, and I'm going to read it because it's such a great quote. We only refer to home therapies those patients we are sure of their candidacy, but not those who are in a gray zone. We may be missing some patients due to selection bias. Since the criteria used in programs are variable and some out of date, we came up with an as inclusive list as possible of absolute contraindications. This was compiled in consultation with the working group and provincial home therapy chairs. The first 3 apply to PD and home hemodialysis, and the last 3 to home hemodialysis alone. So just to go through them briefly, unsuitable home conditions include the unhoused or those living in extremely cramped living conditions and lack of facility-based independent dialysis units. We know that only a minority of programs have independent dialysis units where a patient can dialyze independently outside of the home environment affiliated to a hospital or healthcare facility. So this was included. Second being significant mental health barrier and no dialysis support person directly available to assist in the home. And the third, significant cognitive impairment, brain damage, dementia, and no dialysis support person. And then for home hemo, uncontrolled seizure disorders, diabetes with hypoglycemic unawareness, and unstable ischemic heart disease. The third clear step is offer home therapies if there's no absolute contraindication. So outside of KCC, mainly nurse navigators and home dialysis nurses, and then nephrologists provide introductory resources. Only a small number of HD nurses were empowered to do so, bearing in mind not all programs have nurse navigators or even a partial position to fill this role. We have multiple resources available on the BC Renal website. However, there was a variability in the resources used, and some weren't familiar with the resources available and what is best to provide an introductory or snapshot overview of the home therapies. Our patient partners emphasize a need for an accurate representation of the practicalities of the modality and resources, not just a happy, positive, rosy lens on home therapies. We therefore collated a list with curated introductory resources. We didn't create any new resources, we just used what was available and fit for purpose, and suggested offering home therapies about 1 to 2 weeks later, bearing in mind that too much of a delay may make the patients less receptive to transitioning to home therapies as they become quite comfortable, as we all know, with in-center dialysis. I'm just briefly going to touch on the resources we're recommending. So as a starting point, we have the newly edited Dialysis Options in BC booklet, which has been made more concise, formatted, looks really nice and modern, and it shows the lifestyle, clinical, and financial implications of the modalities, as well as the patient's roles and responsibilities required for each modality in a very visually appealing format, as I think you would all agree. The other resources we included were the most recent 2023 home therapy webinars for PD and home hemodialysis. These webinars, facilitated by Janet and Mike Beverlacqua and the wonderful KCC and home therapy multidisciplinary teams, are a great resource for patients and, might I add, as well for staff. I watched them and did learn a few things. Participant feedback from the annual webinar since 2021 on what they found most valuable included hearing honest, real patient perspectives from actual patients. I like the first quote. Hearing the PD patient was excellent. They were clear and honest regarding challenges and overcoming issues. They also appreciated visuals regarding the modality practicalities. Participants said they liked the hands-on information. The photo showing the storage of supplies gave me an idea of the storage space required. And you'll see later, a bit later in the talk, why we're emphasizing their utility. Finally, the It's Better at Home video series has a very positive spin on the modalities and does emphasize benefit, but it shares very helpful information with many diverse patient perspectives represented, so we have included them. The next step, if the patient is interested and has no absolute contraindications, they would then be referred to home therapies for further education and a formal suitability assessment. In most cases, nephrologists and nurses were recorded for who can refer to home therapy. Different programs have different ways of making referrals, depending on their system and the availability of an EMR. Therefore, we haven't recommended a change to current practice for this documentation part of the pathway. The BC Renal Home Therapy Suitability Assessment resources are widely used by the program or have been adapted as such. The emphasis here is on a systematic, holistic assessment. So, however you've adapted these resources, we're happy with that as long as it's done systematically. The functional assessment looks at dexterity and basic functional ability for the modalities, and the home therapy suitability assessment looks more into detail into cognitive ability, the home environment such as phone lines, water supply, electricity, as well as physical aspects and the ability for self-care. Depending on the program, it is either the nurse navigator or home therapies team that does the majority of this, aided by the social worker. And the home therapies team often is called in to answer any other specific questions or concern and provide more detailed education as appropriate. Again, since this is a program and human resource specific issue, we're not specifying a role to do in this assessment, just that it's done, again, thoughtfully and systematically. In the assessment, if a modifiable barrier is identified, for example, a patient is recovering from an acute illness or they're moving house in a few weeks, we suggest a social work referral to facilitate access to community resources as appropriate. Barriers by definition can be overcome if sufficient support is available to the patient. The patient should remain as an action item on team or transition rounds until their status is confirmed. The Penticton OneNote system is a great example where team communication is cohesive and accessible to all. Patients won't slip through the cracks or be overlooked, as they have a section in orange for existing HD patients or potential PD or home hemo patients, as well as for new starts, flagging independent candidates in the purple box. This is a great quote reflecting the success of the system. Challenges with communication within the program have improved. This system allows any member of the team to identify where the patient is at in their journey. Finally, once the patient is confirmed to be transitioning to home therapies or definitively not to be a candidate, we suggest clear documentation in a visible and accessible location for all providers that come into contact with the patient, as well as, again, that communication element with the primary team, patient, family, and on transition or multidisciplinary team rounds. One would then move on to access referrals and transitions, which is out of the scope of this project, but will be a next phase. This is what the draft pathway looks like, all collated onto a simple one-page document. The final version will be much more beautiful and professionally formatted by the BC Renal graphics team. And we envision it being used as a one-page tick sheet for each patient, as well as an easy resource for sharing it with new staff who are unfamiliar with the process in its entirety. Ultimately, we hope that by teams following this process, they will ensure that each patient is adequately assessed for home therapies in a patient-centered way, and if deemed eligible and interested, given the opportunity to dialyze at home. The PROMISE module is also being updated, particularly the absolute contraindication list, to be in line with the new criteria. And this update will be out soon, and the PROMISE team will kindly provide us with a one-pager and short instruction video, which we will share as part of the education rollout of this program. This is the collated list of resources that can be patient-facing with the QR codes for easy access. This is, again, just for the a draft. The final version will also be formatted professionally by the BC Renal graphics team for the provincial rollout, and it can be printed in a poster format, for example, for display in a dialysis unit waiting area for patients to access it there. Looking at other findings, about a third of respondents recognize the lack of a standardized workflow and process for home therapies as being a barrier to referral, as well as the need for a standardized screening checklist of absolute contraindications. Similarly, about a third came forward with a request for more home therapy in-service education and updated resources. We have established that continuous maintenance training is necessary for nephrologists and nurses. And to quote some providers, I think our modality educators may be biased towards in-center hemo. And we need more education opportunities for home dialysis, like the PD Basics course. Remember, the full multidisciplinary team contributing to and participating in staff education in home dialysis gives a unified message that builds individual as well as patient-level confidence in home therapies. We know that home therapy champions, so by this I mean staff who are supportive and knowledgeable regarding home therapies, have been critical internationally in increasing the uptake of home therapies, as reflected in this quote. Champions have also helped programs flourish by motivating teams, building programs, and keeping local practice up to date. Most of the surveyed centers could identify a champion, but this was predominantly the nurse navigator acting in this role. Remember, there's a need for a pool of champions in each center, especially since not all programs have nurse navigator positions. So I'd like to encourage you all at this point to be a champion in your program. All 7 of our patient partners in open-ended questions brought forward the need for peer mentors. These are quotes relating to peer support. It was felt the sharing of lived experience would help with preparedness, as it would give a clear, realistic account of the modalities. We know that trained peer mentors are in an advantageous position to address questions and concerns of newly diagnosed patients in comparison with general healthcare professionals, as they have personal insights which are very powerful and therefore a stronger sense of awareness and relatability. To read this last simple but also powerful quote, there's a definite benefit in talking with others on the treatment. Peer support is important for mental preparedness. The recommendation for programs to facilitate peer support for home therapy modality decision-making is recognized in the KDIGO 2023 consensus report. To read this quote from Jeff Pearl, dialysis programs should facilitate peer support because they provide vital and unique insights for new patients considering home therapies. Peer support is also included in this figure on the left, which shows the interplay of technology, the environment, and support in enabling dialysis at home. We are therefore recommending in the pathway for patients to access peer mentoring via the Kidney Foundation Wellness Hub. Depending on the patient's need, the Kidney Foundation National Program matches trained volunteer peer mentors with patients requesting one-on-one phone conversations. There are also group sessions and more patient forums. And the Kidney Foundation has kindly agreed to help us keep track of home therapy patients accessing this forum for modality decision-making after the rollout of the pathway to help us assess uptake and need and improve. Patients can also step forward to become peer mentor volunteers themselves. Benefits to volunteers include networking and interpersonal interactions, increased self-awareness, building a sense of community, and personal growth, to name a few. The Kidney Foundation has a limited number of home therapy patient mentors because in this unique area, using mentors from our partners in areas like Ontario may be a challenge due to existing program and equipment differences. Therefore, we're also hoping that through this project, interested new mentors will step forward or be empowered to step forward by their care teams. The process to becoming a peer mentor is easy: a simple application form forwarded via email, a phone interview, and a 3 to 4 hour long training session at no cost to the volunteer. There are also optional regular meetings and further training opportunities for interested mentors, such as becoming a facilitator for a peer engagement group. Patient partners also voice the need for more realistic, factual, and honest resources, depicting visually the realities of dialysis in the home and the changes necessary to be implemented in the home environment for each home therapy modality. Options need to be presented openly and honestly, not just a positive spin on home modalities. And as this KCC nurse so rightly said, in KCC, patients find it hard to conceptualize dialysis at home. These pictures obtained from the Abbotsford PD program show PD supplies and the machine in a home environment. Although you might think it may seem off-putting to patients seeing the requirements and implications at this stage, this is preferable, I think, to them seeing it for the first time when they get their first delivery of supplies. So our next steps for the guide is to assess its feasibility and usability at 5 sites, including Surrey Memorial, Abbotsford, Royal Columbia, Kelowna, and Prince George. We've had multiple education sessions with the sites, and we'll be asking for feedback from them at regular intervals over the 3-month pilot to help us refine the final pathway before provincial rollout mid-year. Training will also be added for the updated PROMISE module. We will assess the guide in line with provincial metrics after the provincial rollout. There'll also be more opportunities with the rollout for provider education to increase the experience and comfort of providers, as well as other projects stemming from this, such as reviewing existing patient educational resources, aligning them with what patients want and simplifying access, the modality transition component, and eventually formalizing the role of the navigator nurse. So generally, there's no one solution for expanding the use of home dialysis. Important considerations include 4 key areas for project implementation and further research. Firstly, home dialysis organizational culture. This means the values, beliefs, and assumptions in the programs. This should be addressed, and there is a need to develop and test mechanisms that build a culture of confidence around home therapies for healthcare professionals, patients, and care partners. Clinical champions play a key role in spearheading implementation initiatives and help overcome resistance that may occur at an organizational level. We need to understand the optimal approaches to share expertise and knowledge within and between programs where appropriate. As we saw at BC Kidney Days, there's a lot of great projects taking place in this space. And I'd encourage collaboration, especially where there's overlap, so we can all share insights and benefit. Tools should be developed and tested that assess and address physician and healthcare team bias in modality selection, and educational interventions targeted accordingly. We should look to build our peer support network, both from a mentor and mentee perspective. In this fairly new and nuanced area, we need to evaluate the best methods and optimal timing of peer support and its impact on patient-reported outcomes and home therapy uptake. So finally, my take-home messages. All individuals in need of maintenance dialysis should have home dialysis as a potential option. And remember, in 2024, few absolute contraindications exist for home therapy. High quality, up-to-date education and clinical experience for healthcare professionals, be it nephrology trainees, nurses, and even nephrologists around home therapies are priorities. Individualized care, patient choice, education, and shared decision-making are central to modality selection. At this point, I'd like to thank our working group members, especially our stellar patient partners who so generously gave their time and expertise, Julie and Zamira, our project manager, Linda Turnbull, and the support from BC Renal, particularly Sue and Salma from the administrative side. Kidney Foundation has also been fantastic, and Kate Chong in advising and developing the peer mentoring element, and also everyone who participated in the surveys who gave input in the various meetings. And I am happy to take any questions, and if we don't get to them or you want to email me directly, please do so. I would appreciate any feedback or input. Thank you.
Thanks, Megan. That was a tour de force. If you want to stop sharing, that was an excellent overview of an area that's top of mind for everybody, and something that we all try and do, and you've really nicely conceptualized and articulated all of the problems. There are some questions. I encourage people also to put their hands up. There's a question from Dr. Copeland about whether or not you think the screening tools that have been in existence have ultimately ended up highlighting barriers rather than identifying opportunities. And so Match D was intended to, I'm sort of paraphrasing what he wrote. The Match D was intended to be used to overcome in the latter way, so it shouldn't have been creating barriers, but it in fact might have done the opposite. So do you think that even if there are existing tools, do we need clearer guidance on how you use the tools going forward?
For sure, and clear guidance in our context, because we know every system is unique, even within Canada. So definitely more guidance specific to our setting.
Yeah, and I think maybe socializing the concept that standardized tools have always been shown to be better to produce outcomes, especially when they've been validated, than random questions asked by random people. So even with the best intention and the best input. So that's great. And Dr. Schwartz is asking or commenting on the fact that there's variation in home dialysis rates between the sites even within health authorities and within health authorities and between physicians? Do you have a sense of what accounts for this and how to address it?
There definitely is, definitely between physicians and between programs. And I think the work that Alexandra and team are doing with the provincial metrics, we saw some presented yesterday at the PD committee meeting, better understanding what the metrics are capturing at a finer, more nuanced level is going to provide really valuable insights into the reasons for that. But I think bias and misconceptions among everyone are still a big problem. And I think addressing that was an important first step.
Yeah, and I guess maybe a corollary question. I know that there's a Dr. Perkel has his hand up, so he'll be next. But one of the things that I wonder is, much like the patients need to see the real truth, I wonder if both our fellows and as well as staff nephrologists need to actually, if they're not actively involved in peritoneal dialysis training and peritoneal, like to go and do a home visit, to go and see what actually the questions that are asked, et cetera, because I think that may help in a different way, but you know, that might be interesting.
And they're good opportunities like Baxter, the PD Academy, and
that's right.
It's a great opportunity to refresh knowledge.
Yeah. Dave, if you want to, we can unmute you, and then there's a question from Brian Forsley. And I also want to thank you, Megan, because you not only presented it well, but you've left enough time for questions, of which there are many. And so we are going to be able to have a really meaningful conversation. So I appreciate that. Dave, we'll unmute you.
Sorry, that was a mistake. No questions.
Oh, okay. So the question from Brian Forsley comment is that there's a common barrier related to patient disposition, factors like personality, like naturally risk averse and change averse, and personal confidence, low trust, etc. And also the mindset of healthcare is better left to professionals. I don't want to do it. So he's wondering whether or not there's a major opportunity to hone our approach to those factors when we approach certain patients. Is there any background work or resources that you've seen around that? I think it's an interesting question, right? It's too personalized medicine based on personality and learning styles, I suppose.
I think the peer mentors, and specifically them really trying to be to be attentive to the specific asks of the patient, not just giving them someone to talk to, but giving them someone to address the particular challenge they're having. Obviously, some people immediately say no, but patients who are open to hearing more, I think getting that perspective from a trained peer mentor is exceptionally valuable. And there is a growing amount of literature in showing that the peer mentors are really helpful in addressing that particular group of patients. So yeah, it'll be interesting to see as our program expands how that uptake and utility is from a patient perspective.
Yeah, and it may be, I mean, just the corollary is, and Dave, I know Daniel has his hand up, so he'll be next, but it may be that I think what Brian's saying is maybe better characterization of patient personality and learning choices matched with peer review so it's not a one size fits all. There are people, you know, so it's an interesting concept, right? We talk about precision medicine, but we don't talk about precision decision making based on personality type, etc. So it's an interesting concept. It's obviously a big area that we could look up, but Daniel?
A great presentation, really enjoyed it. A bigger question, I think a lot about the systems we work in. It's a lot more work for everyone to get patients home. Interestingly, for the system, it's actually a lot cheaper to send them home. Mm-hmm. In most industries outside of healthcare, we tend to align incentives. What I see with home dialysis is that we may not be, in that the people who put in the work to get people home have worse lives and more stress at work, have to work harder to achieve the outcome of interest. I'm wondering if you have any thoughts about alignment of incentives as a strategy to improve home dialysis rates.
Yeah, certainly. I think the work that's going on in the US is looking a lot into that, aligning incentives. And I think it ultimately will benefit the system. So definitely more work in that locally would be very helpful because we can do it. But if, like you say, we're not really getting the incentive to do so, it is going to interfere with our numbers. So yeah, definitely.
Yeah, do you have suggestions, Daniel, in terms of aligning incentives?
I mean, I do. They might be perceived as a little bit radical. And I hate to say anything great about the American healthcare system, but there is legislation implementation through Medicare to use financial sticks and carrots to drive site behavior. And it has not been exclusively successful, but there are elements that have been successful. We've also seen in the UK where sticks and carrots around primary care and preventative care has been very effective. So I do think that healthcare currently is unsustainable fiscally, and that investing for more socially responsible, fiscally responsible healthcare is a reasonable thing to try. And that could be at any level. It could be at the health authority level with bonuses, financial bonuses for hitting targets, and penalties for missing targets. There's risks with both those, but it can go down to the smaller level within units. The way physicians are reimbursed. All of these fiscal elements we've generally said are untouchable. And I wonder, given the success in other industries, is that something we need to revisit?
Very thoughtful, and I don't disagree at all. I think it's about, could we catch that as a pilot project, right? Like if there was a way to construct something to see if that actually changed behavior. I'm just noticing there's a question in the chat, and Mike has his hand up, so maybe I'll go to Mike and then I'll go back to the chat.
Sure. Thanks, Megan, again for that. That was a really well presented and thoughtfully organized talk. Thanks. Just to follow up a little bit on Daniel, I think that is a really interesting thing to be thinking about, because you're right. Once people are at home and stable at home, I think they definitely are less work, quote unquote, on the system, but getting people and moving them home is definitely often Herculean, and I think that's something that's important. And I think I was just going to come at it from a slightly different angle about the importance of the home champions in the facility dialysis units, because there is a lot of contact with the patients there. And I think I've been seeing this for the last 25 years, that the experience that our in-center colleagues, nurses in particular, but physicians to a degree as well, their contact with the home patients are when they come in with complications. And therefore their frame of reference is really such that the home patients have all these issues, where in fact the frequency of those issues is very low, and the majority of the time those patients are at home. So that's, I think, where we really need to be. Adira, your comment about the nephrologist going in and seeing the home is important, but I think that also applies to our staff and our nurses in particular, so they have a better sense of it. And then the other thing, which is also maybe a little bit tangential, but Daniel, your comments about incentivizing, and I won't use the word incentivizing, but one of the areas we're looking at in the home hemo side, at least, is not creating financial barriers for patients at home, at least, if not an incentive, but to be looking at ways to get rebates for hydro and water, rather than just tax credits, which most of our patients have come back to us saying, I don't really have tax credits that are beneficial to me. So that's one of the projects. Oh, I shouldn't say projects. That's one of the things we're looking at from a home hemo side of things. But Megan, I'm just interested in your survey work. Did any of the financial barriers come up in any of the groups as you were talking about them?
No, it was mainly geographic barriers specific to certain areas. For example, on the island, having to travel for like PD tube insertions and that. But financial barriers didn't come into play at all.
Okay, it is interesting. I was at a meeting and I heard in France they have a very small uptake of particular home hemo, and also I think a relatively low uptake of peritoneal dialysis. But the French government actually pays the patients a small stipend per week to be doing their therapies at home. And that's a true incentive, but the rationale behind it was you're saving us having to pay X number of people in the healthcare system to be providing your care. So we should incentivize it a little bit for you. And it was a relatively token amount, somewhere in the neighborhood of around 30 to 40 euros per week. But it was something that was an acknowledgement to the patient for the work that they were carrying on and avoiding. And that I think is also a radical way in our healthcare context. But I do think we need to focus on eliminating any barriers of water and electricity, which may seem small, but for our patients at home is just an added cost for them doing the work that we would be doing otherwise. So, but once again, thank you. That was a really excellent talk.
Yeah. And and thanks for those comments, Daniel and Mike. There's another question about, did you find any programs or interventions to improve patient problem-solving abilities? And you didn't mention anybody with learning disorders and how to support those. I think that it's an interesting thing, cognitive impairment is not an infrequent complication of uremia, and problem-solving issues may be something. So is there anything in the literature about that?
We didn't look in fine detail to specific patient groups, but certainly looking at the patient experience in this process will be part of the evaluation of the process, looking at it for specific subpopulations as well, both varying levels of physical and mental abilities as well as geographic locations.
Yeah.
I think as far as possible, we make in the assessments, like the cognitive assessments, we do make some adaptations for people at different levels. So just checking, do you have any?
Yeah, I know that was just for Daniel because he had his hand up still, but I think he took it down. Anyways, no, I think, this has been an excellent presentation, as Mike said, very thoughtfully put together, and logical, and I think educational for all of us to think about these. Oh, Anurag has his hand up before. Okay, go ahead, Anurag.
Oh, thank you, Megan. I just wanted to quickly make a point that one of the challenges we have is maintaining people on PD. So once they go on PD and they live in a rural community and they're getting older, it's great that we have PD assist. But, think about patients who are getting older and their needs increase, and then we switch them to a hemodialysis. That's devastating. So that's where I think some of the gap we have is that how can we keep people on PD when they go home and actually want to go home? And I think from where I am, we partly fail them because then we don't have options but to switch them to, either in a way force them to choose not to have dialysis, choose palliation, or to convert them to hemodialysis. And I think that needs to be addressed at some extent.
Yeah, for sure. At least having a long-term care with the ability to do PD like some areas have is very helpful. Obviously a patient has to move home, but it's
I think there's, a number of jurisdictions have also struggled with this. There's also de-escalation of PD to reduce the burden of exchanges. There's, as you say, maybe training community workers to help so that they don't have to switch. I think these are all things to be explored systematically, but I think we have to figure out what is the major root cause of and big pain points so that we actually get the right solution for the right problem. Dr. Burkal, you have your hand up again. Is that a real one?
Yeah, just to touch on to what Anurag was saying, I think as we look at our changing population of patients on PD, we're typically getting older, and a lot of time we're doing destination therapy on PD to keep them at home. What I think one of the biggest challenges that I see is the impact on families. And, although it's less costly to the overall system, it is often very costly to patients' families. And I think that is what I don't want to call it a barrier, but that's a major challenge for us. And I think that's an unexplored way where we support them. Yes, we can do PD assist, but the reality is a lot of patients rely on their family members, either sometimes young family members to provide care. And this is a 24-hour, 7 days. So it really has a major impact on their life. And so I would always be supportive of exploring that and how do we support the families, not the patient as much, the families more, whether it's, you know, as Daniel was saying, any sort of financial, some form of incentives, disincentives. Like I don't think the incentive is to the nephrologist. We need to find something for families.
Yeah, patient level opportunity cost is a big thing. Household income goes down, etc. So yeah, that's definitely an area that on a system/policy level would be interesting to look at.
Yeah. Anyways, so thank you everyone for your comments. Thank you, Megan, for really provoking a lot of deep thought, and obviously a lot more work needs to be done. We're not the only and first people to address this problem, but I think your very systematic approach at is there something that we could do provincially to address a number of these different things is really outstanding. So thanks, everybody. I also say that you win the prize so far. You had 95 attendees at the height, and that's a very multidisciplinary group of people that attended from different provinces, not just from British Columbia. And as I said to everybody, this is posted on the BC Renal website as well. So both the questions, comments, as well as the presentation itself. So again, thank you very much for starting out February with such a high bar.
Thank you. Thanks very much.
Bye.